My name is Anna Rotkiewicz. I am a associate professor in University of Texas Medical Branch in the Department of Internal Medicine and Division of Geriatrics. I am a geriatrician for 20 years. So I am kind of, I would say, still new to the clean language since you are doing this for more than quarter of the century. I started a few years ago uh, on the beginning, just knowing few questions, and this is when I think I started to see the difference between previous work which I did with the patients in interview versus what I started to experience after the introduction of clean language. Well, first of all, I think the major difference was that it was invitation to the storytelling.
Mhm.
Uh, and normally we are interrupting patients like in 15 seconds. This doesn't really allow you so much because you really don't have so many questions, I think. And when the patients first see this new way, they are sometimes surprised because I'm not um, introducing the tool which I will be using to the patient, obviously. But they are also immediately seeing the interest. And I think this reminded me, this situation with the new discoveries during interviews, something what my mentor used to say, the doctor, you are not having interesting cases? Yes, you don't, because you are not interested. And I thought about this statement, for many times during incredible discoveries which I had during this few years, specifically recently, when I started to see the patients which, when you take probability, I shouldn't see so many, so frequently, such unusual cases. Um, so besides the fact that, I think people feel validated and the less isolated in this doctor office because it's instant connection, I think, building. And the data collection also is changing.
Mhm. And so
So first,
so you're seeing more interesting cases as a result of asking clean language questions. Tell me more about that.
I can give you maybe few examples because I think it's best illustrated by the examples.
Hmm.
First of all, I think it's the cases which are underdiagnosed, I see. Um, Patient may come for a very long time. Sometimes this case, which I have in mind, is 2 years. Patient had liver biopsy because of the abscess in the liver, which is already by itself unusual. But the discovery of why the patient is still on narcotics 2 years after the biopsy was for me puzzling. Um, and through the questioning, I was able to find out that this pain in the liver is indeed the grief after the patient, around actually the time when she got liver abscess. I think it was really very close proximity, 2 months after or something, after the death of her son, and she was feeling responsible that she didn't do enough. And I think feeling guilty that the son of her died. And it was one session when suddenly I think she also understood that the pain, it's grief. And when she was able to start, I think, to experience the grief, which she was holding back, I think this experience she was holding back, um, suddenly she didn't need narcotics. She didn't need any pain medication whatsoever. And we worked a little bit on that discovery, and I was helping her grieving through the next few meetings, every month. Um, so this was, I think, the first kind of eye opener. The second, I think, very interesting was a patient who experienced 3 times delirium in a row, coming to the hospital within 6 months. And since my patient has a lot of different disorders, geriatric syndromes, it's very difficult to peel, this onion, what is what.
Mm.
And it was very difficult to interview the patient, obviously, because a patient is deliric. So they are not attentive. They don't remember many times things, and they can't concentrate on really storytelling. So we were able to ask questions which were kind of showing me something is not right. But I really didn't know where to go with it. And I think the discovery was made by talking with the wife of the patient, who was invited to this storytelling how this delirium was presenting and what happened in between those episodes. And end of the story was the patient was actually having not so much delirium. It's like related to his medications, which previously was assumed, or fact that he's a diabetic, so maybe he's not taking medication, but he did take medications. And despite that, he was showing that he had strokes, and the strokes were like on and off, on and off. So unusual. So with the storytelling and looking at this a little differently at this case, I found out that he has actually autoimmune encephalitis, which is very unusual diagnosis, obviously completely different treatment than everything before. Um, I
And
think
the encephalitis was causing the episodes of delirium.
that's correct. That's
But
correct.
nobody would normally think, oh, that's repeated delirium to be autoimmune
Yes,
encephalitis. They would think it
yes,
would be a
that's
urine
correct. Because
infection or something.
yes, specifically in patients with minimal cognitive impairment, when they are in the hospital, frequently they experience it. So the unusual, I think, case was that yes, he had those episodes which look like delirium combined with the stroke, which is already something different, but also inviting the wife
Hmm.
to with this kind of different questioning. So she was really giving very detailed story. That's, I think, the heart of the problem, that they give different story when you ask them those questions. I think they immediately go to this deep state of thought, and instead, me questioning the like we question about the pain, and where is the pain, and how long is the pain, is it sharp or is it dull, those kind of questions are not really giving them space for the story. um, so I think this was very interesting. Another case which I have in mind is a patient who was having post-traumatic stress disorder, and I think a lot of doctors were not really seeing her as a patient who has this new complaint, and oh yeah, she has always the complaint with her tiredness, fatigue. That's yeah, she's 80 years old, so you have to be fatigued when you are 80. When indeed, actually, patient was having new onset of the autoimmune disorder, Wagner's, which we diagnosed her later, associated with the thyroid cancer, which is again very unusual, incredibly unusual presentation of this autoimmune disorder and cancer at the same almost time. Um, and I think the most of the time, really, it is opening the space for the patient. That's what caught my attention. That's the difference between clean language questioning and regular interviews.
And that's the difference. The clean language questioning opens the space for the patient to tell their story. And then
Yes,
they tell you a whole lot more and different
yes,
information than they would tell you in an ordinary way.
that's correct.
To what
Big-
extent, and I suppose one of my questions is, um, if you're not getting unusual cases, it's because you're not interested, your mentor said.
Yes, that's correct.
What's the relationship between your interest and clean language?
Um, what is the difference between the interest
Mm.
and using Queen language, or the interest and not using Queen language?
Yeah, how are they related?
Um, I mm, I think, clean language but its nature, it's I would say it's curious tool.
Hmm.
And curiosity, it leads to more allowing patient to speak than the interviewer to talk. Many times we really talk at the patient, not even to the patient. So I think that's the big difference. You don't have so many words, to use. So it's like you shut up, doctor, and allow the patient to talk.
Now I can hear the people watching this video going, but that's going to take ages. They haven't got time to let their patients talk.
Uh, Not really. Um, Beginning is many times a little surprising because patient tries to go to their regular interview.
Hmm.
And when they try to do that, because they are expecting the next doctor asking the same way, maybe they're already taught or learned how you're supposed to answer. So I gently bring them back with again the same, tool with one, two, three questions to the what would you like to have happen? And I don't ask what happened, which would be the first question which we normally ask. But then when they think about it, like what happened? What do you mean? And this is, I think, when they start to shift to the different area of the brain, not thinking about, that, well, what would be the next question maybe doctor will ask, but why why I'm even here? Um, and then obviously, trying to get the desired outcome from the patient. What would you like? It's, oh, it's about me, what I want. Many times we are saying, to the students, yes, you didn't find really what happened to the patient, because when you ask the patient, you were not really interested. You wanted the patient to meet your expectations, not meet patient expectations. And I think that's where it's changing the route of the patient answering the questions, because now it's about them. And I think they feel it, kind of, they relax in the body. You can see that the changes in the body language, they go deeper to themselves. They are not now concentrating on the pleasing the doctor.
And how long does that take?
Okay, I will give you example just from the last weekend. We had patient who comes to the clinic, to the hospital again because she was having a lot of shortness of breath. So that's unusual, specifically if you have multiple reasons, biological reasons why you can be short of breath. And by the way, I can't swallow either. So now you have a second component with almost the same time. And yeah, the patient had something in the past which could explain that second phenomenon. So I come to the bedside and I start to ask her questions. When you could not swallow, what kind of swallow? And she started to explain exactly, how he intermittently cannot swallow and what she can swallow and she can. And I think at that moment, the husband starts to be very impatient. It's like, oh, okay, when you stop to asking about this, the diet thing and all those things, may I have my family member to talk to you on the phone? And this is really catching the attention of the physician, because it's rare, and I didn't see this on before two times, when the patient was previously in the hospital within actually the same week. which is really looking bad at the doctor like me, having the patient readmitted. Uh, this is another dynamic. There's something going on here. So that's red flag. And I still pursue, with asking another question, and I got the same kind of thing, this impatience. So I said, okay, what I don't know about the patient, maybe it would be really now useful to talk to the son. And then we will check, the patient mental status. And we found out that actually the whole situation was completely different. Patient is changing environment because something is not going right. They cannot control their life anymore. And the dynamic is very interesting because turns out that she was always this matriarch who was running the show. Now she has dementia, and dementia has this component of anxiety. But there is another component. The husband was always this kind of almost like a child of the patient. So now he's very nervous because the child is now left alone, almost like making decisions, trying to be helpful, but this is new situation for him too. So now this feeds the his anxiety, feeds her anxiety. So we completely changed, that the route, we will be going with, asking maybe psychiatry a little bit to step in and help, and the son to help in, because this shortness of breath is not actually about shortness of breath, which you think because of the lung or because of the heart. It's this anxiety of existence.
Mm.
So sometimes those symptoms are showing like masquerading, I would say, as something completely different, the psychosocial components masking as something what, oh yeah, people have shortness of breath and sometimes the disease is progressing. So,
Mm.
and the geriatric who will ask another question, yes? Oh, unless you listen to the patient and you listen to the situation around.
And these older patients, presumably they all have lots of things wrong with them, and they're going to have lots of interesting family dynamic changes and things like that. It's almost inevitable with an older person that all this stuff is going on all at once. Do you
Correct.
think do you think that the clean language is helping you to see the wood for the trees? You're able to see the whole rather than the parts.
That's correct. That's I think the difference, that you can see the from this foggy clinical landscape, you are coming to this very focused, almost zoomed area, which patients actually lead you, or those dynamic lead you. Um, I think it also sharpens the doctor um, at that moment attention, which many times even if you talk to people and they start to kind of go around like tangential speech, then you were like started to think about your things completely not.
Yeah.
Here you really are listening for those cues, which will get lead maybe to the next question. um, I think that's what also happens. It's not just that the patient is more focused, but also and open, but also the physician is more focused.
And when the physician is more focused, what difference does that make to them, to the physician?
I think first of all, you are starting to be more. I mean, when you are focused, you are having more ability to reach to your, I would say, store of information. One thing. So it's almost like the other things are brought to the surface, which means the experience brought to the surface, um, which normally when you are not very, very attentive, it's almost like in meditative state. But this is specific meditation. It's this very attentive medication, a meditation to the patient clues. And I think once this happened, you can see the pattern clearer. And if this pattern is not making yet be visible, then you ask those more questions. So you pull, and it's like, oh my, this pattern is actually shifting now. So I think it's allowing physician to be um, much more aware of the differences, which are starting appearing than just kind of thinking about, okay, that's my template. I have to go with those questions to just write me nice story. Like we have the templates right now. I think that the change happened when the forms started to appear, and now we are kind of very, very structured. And I think leaving the structure and allowing the brain to go to this like a new way of painting the picture of the patient is um, it gives the physician ability to make different connections, and with different connections the different pattern appears. And if this is unusual or something which is like, oh no, that's not what I expected, so now I am surprised, so when I'm surprised I am curious more. Yeah, very, very much. I think the surprise, I would say it's something what motivates the physician to further question and be curious more.
Hmm. And I imagine doctors of all kinds being worried about asking elderly patients with multiple illnesses, what would you like to have happen? Because they might think, well, I can't help this elderly person to be young again and be dancing down the street and going to nightclubs. Um, what would you say to a doctor who's worried about asking what somebody actually wants?
So I would think that maybe they suffer from attention deficit assumption disorder. Um, they assume that the patient will go all around the city. And when I started to ask the clean questions, it was the first patient I had like hour to spend with because she was just a new patient and she was having some issues with addictions. So obviously she could go to that route. But I think surprisingly, by asking different type of question, which I think it goes to the different part of the brain, frankly, making you focused. Uh, they do not go around. They actually go with the questioning. Um, I would say even demented patient, that was, I think, my biggest surprise, are going to what bothers them right now. What maybe they were having follow up on hypertension. Yeah, that's very possible, but that's not why you're here. And if you meet patient expectations, patient, not yours, then suddenly, they are in a way very joyful inside, and they tell you this on the end of the visit because they didn't expect that to happen. And I think somebody wrote the book, The Patient Will Meet You Now. So I think I was just glancing the book, but I remember the patient will meet you now. So I think that allow the patient to tell them why they came, not like what you assumed is for oh, that's follow up for that or this. Or, previous doctor wrote me in the chart because they had 5 minutes. So many times they are very creative and they tell what they thought, not what the patient really was about to tell them, should they be asked. So yes, I would not worry. I would just try to experiment, like you experiment with the new tool in like area of treatment. For example, we have ultrasound to be able to see some picture, for example, abdominal
Mhm.
organs, but we also then use this ultrasound for the treatment. So try to use this clean language for both, for using, as a diagnostic tool, but also as a treatment. When people are allowed to voice their whatever they came with, um, they will be more satisfied and definitely they will lead you to the right diagnosis.
And that goes even and perhaps especially when they have dementia.
Absolutely. Very, very surprising. Yes.
And for me, the way I'm imagining that is people with dementia seem to have their own way of being in the world, and perhaps the clean
Yes.
language questions can give me some clues to what it's like to be them.
Yes. So I give you example. This patient is um, coming with very severe depression, and she's almost not talking. Um, and she's coming with the caregiver who is a friend. It's not even she doesn't have any family. Only this friend who they had friends for very long time, that decades they were friends. The two couples were friends, but she lost her husband, and now this other older couple, but younger than them, was taking her under her roof. So it's a kind of very interesting story already, but this caregiver is very sad, and I would say frustrated also, because she's not eating. She has this memory, so he tries to evaluate, what really going on. And um, the story was that by questioning, finally she was able to say, "I lost my voice." Isn't it interesting, that she would like to have her voice back? So what kind of voice is the voice you would like to have back? So the patient was telling, like, now opening, that she was singing in the church, and she had her own um, lyrics, the Christian lyrics, written in this booklet, which from she was singing, her own songs in that church, which she was attending for years. And her place burned. So she lost all this creativity, which I think, was like experiencing, like you have the soul, or your soul
Mm.
put to this book. And then, um, so we started to talk about this voice, how she would like this voice to come back. And this opened her. I was able to, not only he saw what is really this matter, of grief, um, but since then she just started to talk. It's almost like realizing that she lost her voice, the singing voice, the voice which she also put on the paper, which cannot be retrieved now. Um, for some reason, opened her to life again, just realization.
That's so inspiring.
Incredible, yes, incredibly. And she was able to show me on the picture, something was the picture was like, you think 4 years old will draw. And we many times see that patients' decline is like going back in your development. So think about it, when how much 3 or 4 years old can tell you if you are asking very sophisticated questions. So simplicity of clean language, I think, allows those demented patients to speak their language of a child, this little child in this case, who lost her voice,
And potentially get it back.
and potentially in a
Yeah.
different way get it back. Yes.
Oh, thank you. Now we're at the end of our time. Is there anything else that I should have asked you about that we should squeeze into this video before we close?
Yes, that I mentioned maybe in between that we want to communicate with the patient and their surrounding, which means maybe they loved one, um, many times the caregiver. So the patient, when is helped, will definitely be happy and want to celebrate. And supported caregiver wants to celebrate that they have now something else to work with, because they see this spark of hope. Uh, because as I said on the beginning, many times you will uncover the real treasure, in the treasure box of the patient, not yours. Uh, So I will leave you maybe with this metaphor by using clean language. First of all, you will be very joyful because it will spark your interest and new discoveries. You will be successful, maybe in the domain of helping the patient and their caregivers, but also you can probably present interesting cases on your conferences. So something for you will be there, I promise.